So I'm going to talk to you today about adoptive T-cell immunotherapy to treat patients with B-cell malignancies. So acute lymphoblastic leukemia, B-cell non-Hodgkin's lymphoma, and chronic lymphocytic leukemia. And so Dr. Stewart was asking me about the title of the talk, Tumor-melting T cells for patients with B-cell malignancies. This actually came from a patient that we treated on the trial who, within a few days of receiving his T cells, was explaining that these large, hard, craggy lymph nodes in his neck was starting to feel like ice cubes slipping around underneath his fingers and dissolving over the course of a couple of days. And it wasn't long before the Fred Hutch development people actually had that up on a billboard on 99 with a big check saying, pay to the order of tumor-melting T cells. So I don't know if any of you saw that, but that's where the title of the talk comes from. There are a couple of disclosures just to put up there. Okay, can everybody hear me okay? Yep, okay. So I think most people are probably familiar with the idea of adoptive T-cell therapy. Essentially, it involves a collection of T-cells from a patient with a malignancy, some process of expansion of tumor-reactive T-cells, and then reinfusion of the T-cells back into the patient to try and induce an immune response directed against the tumor. And for many years, this has been done by repetitive antigen stimulation with some sort of tumor antigen, whether it be a peptide or irradiated tumor cells or a lysate. And the idea of this was that you would expand and enrich these populations of tumor-reactive T cells that could then be given back to the patient. And these approaches produced some sporadic, very impressive responses over the years, but the problem was they were highly sporadic and the responses were few and far between. And there are a number of reasons why this may have occurred, but one of the reasons could be that this sort of active repetitive antigen stimulation at a long period of time in vitro was actually driving differentiation of the T cells and such that they weren't really in an optimal state to engraft after infusion and induce an immune response. So more recently, there have been developments in genetic redirection of T cell specificity by engineering with tumor antigen receptors. And this allows us to rapidly redirect the specificity of a polyclonal population of T cells towards a tumor antigen in very quick order, within the order of about 2 weeks or so. So this can be done by introduction of TCR alpha and beta genes or by chimeric antigen receptors. And that's what I'm going to talk about today, is the use of chimeric antigen receptor modified T cells targeting CD19. So CD19 is really an excellent target to treat patients with B-cell malignancies. It's a lineage-specific antigen, so there is essentially no risk of off-target toxicity to non-malignant tissues or tissues outside the B-cell hematopoietic lineage. It's expressed at high levels and it's stably expressed through all stages of disease in patients with ALL, non-Hodgkin's lymphoma in the B-cell lineage, and chronic lymphocytic leukemia, even occasionally expressed on some myelomas. So it really is a very good and in some ways a unique antigen to target. So what's a chimeric antigen receptor? So the name basically comes from the fact that it's a mixture of two types of receptors. It's a recombinant receptor that basically gets its specificity from an scFe derived from a monoclonal antibody that is specific for an antigen expressed on a tumor cell, so in this case CD19. And that scFe is fused to intracellular T-cell signaling and co-stimulatory molecules such that every time the scFe is ligated by its target antigen, you get full T-cell stimulation. It's not dependent on HLA restriction as a conventional T-cell receptor would be, and there's the possibility to engineer in co-stimulatory molecules so that you end up with full co-stimulation of the cell every time you ligate the scFe. So this is sort of a way of bypassing many of the mechanisms that tumor cells use to downregulate an immune response by downregulating class 1 and co-stimulatory molecule expression by making a receptor that's independent of those factors on the tumor cell. So we're not the first group to use this approach. There are some celebrated papers by groups at UPenn, the NIH, MSK, who've used CD19 targeted CAR-T cells. And one thing that was in common with a majority of these studies was that there were very unclear dose-response relationships between what you put in, the number of CAR-T cells that you put in, and what happened to the patient, their likelihood of response, their likelihood of toxicity. So this makes it very hard to actually work out what's going on and very hard to develop new iterations of the therapy. One thing we know is that when we make CAR-T cells, these groups start by engineering bulk T cell populations. So we know that there are multiple different functional subsets of T cells in healthy individuals and cancer patients. There are naive T cells, memory T cells, different subsets of memory T cells with different functional capacities. So one of the things that we questioned was that if these groups were unable to find dose-response relationships, was that in part because they were engineering bulk T cell populations that were highly heterogeneous, stimulating them with a polyclonal stimulus to induce proliferation, transducing them and culturing them for a couple of weeks. And at the end of this period of manufacturing, you really don't know exactly what the T cells are capable of doing and where they originally came from. So we had the question in Stan Riddell's lab of whether or not the composition of the starting T cell population was important in CAR-T cell immunotherapy. So we set up a model in which immunodeficient mice bearing human CD19 positive Raji tumours were treated with CAR-T cells that were manufactured from different T cell subsets, so naive T cells, central memory T cells, or effector memory T cells. And this is data just showing the survival of mice who then received these CAR-T cells after tumour inoculation. And what you can see in the CD8 compartment is that the mice that received CAR-T cells manufactured from the CD8 central memory compartment had the best survival, and those that came from the effector memory compartment had the worst survival. So essentially the CAR-T cells that were manufactured from a more differentiated T cell subset did less well than those that were manufactured from a less differentiated memory subset. Moreover, when you actually combined CAR-T cells made from the CD8 central memory subset with those made from the CD4 T cell subset, you actually had a synergistic improvement in the potency with the two of them mixed together. So these studies, albeit in a mouse model, suggested that a combination of CD8 central memory-derived CAR-T cells and CD4-derived CAR-T cells provided the optimal potency and ability to clear the tumour. So that's all very well for a mouse model, but what about in humans? How is this relevant? Well, the relevance really comes from the fact that when you look at either patients or healthy individuals and look in the CD8 population or the CD4 population at the distribution of naive central memory and effector memory RA subsets, that you see there's a highly heterogeneous distribution. So there are some patients who have approximately 90% of their cells have this sort of less potent effector memory RA subset. Conversely, there are some that have very few of these cells and a lot more of the more potent central memory cells. So the idea of actually trying to engineer from distinct T cell subsets rather than from the bulk population was really set up to try and find a much more consistent product and really control some of this variability that is inherent within the distribution of T cell subsets. So that's all very well, but we obviously have to go and do the clinical trial and find out whether this whole thing can work. So we designed a lentiviral vector that comprised an anti-CD19 murine scFv derived from the FMC63 monoclonal antibody that was fused to a 4-1BB co-stimulatory domain and CD3 zeta T cell signaling domain. And this is essentially the CAR, this part here from the scFv down to the CD3 zeta. We also put a non-functional truncated human EGFR tag in the vector, and this allowed us to identify the CAR-T cells by flow cytometry and to precisely formulate the products. So the patients underwent a leukapheresis. Leukapheresis is split into two aliquots, one for selection of the CD4 subset and one for selection of the CD8 subset. Our intent was to select CD8 central memory cells, but in patients who were severely lymphopenic or had high circulating numbers of tumour cells, we substituted selection of bulk CD8 T cells for those individuals. So either way, the CD4 and the CD8 T cell subsets were separately cultured and transduced in vitro over the course of about 2 weeks, and then they were formulated in a one-to-one mixture of CD4 CAR-T cells to CD8 CAR-T cells. So this is the defined composition. The patients received lymphodepleting chemotherapy, and I'll talk a little bit more about that later on, and then received their CAR-T cell infusion about 48 to 96 hours after the lymphodepleting chemotherapy. It was a dose escalation, de-escalation study, and the patients received doses, or a single dose from 2 by 10 to the 5th through 2 by 10 to the 7th CAR-T cells per kilogram. The objectives of the study were really to assess the safety and feasibility of manufacturing and infusion of the defined composition product, but we also do have some data on anti-tumor activity, as I'll go into. The patients who were eligible for this were adults with relapsed or refractory B-cell malignancies, and I'm not going to go into detail about this, but these were patients with an exceptionally poor prognosis. It was not uncommon for them to get off the plane and rather than coming to the clinic, they would go straight to the inpatient service. Many of them had extensive tumours, high levels of disease, and were really in very poor shape with a life expectancy that could be measured in weeks in some cases. We had no inclusion or exclusion criteria based on absolute lymphocyte counts, presence of circulating tumour, prior transplant status, or the results of test manufacturing studies. So this just outlines the characteristics of the ALL patients. So the median age was, as expected, as I mentioned, they were all adults. They had a median of 17% blasts in the bone marrow. 7 of the patients, about 19% of the patients had extramedullary disease. 2 of the patients had CNS disease that was active at the time of CAR-T cell therapy. They were very heavily pretreated, with 69% of the patients having more than 3 or greater than or equal to 3 lines of prior therapy, and a third of them had failed prior allogeneic transplant. Essentially, through this talk, I'm going to refer to 2 different types of lymphodepleting chemotherapies. In the early part of the study, we were really using just a cyclophosphamide-based lymphodepletion with or without etoposide. And then later on, and that's what I'm referring to as non-Cy-Flu. And then later on in the study, we actually introduced fludarabine into the lymphodepletion regimen. It was a combination of cyclophosphamide and fludarabine, and I'll talk a little bit more about the differences between some of those 2 regimens a bit later on. We were able to make CAR-T cells from all of the patients who entered the study, and 92% of them we were able to make the product in that 1-to-1 CD4 to CD8 CAR-T cell formulation. So, of the 36 ALL patients, 2 patients died of toxicity prior to their assessment. So 34 patients actually underwent assessment, and all 34 achieved a morphologic bone marrow CR, which, as you know, in ALL really doesn't mean a lot. It's high resolution restaging that is really much more important. So when we looked at the bone marrow by flow cytometry, 94% of the patients were actually free of disease and in CR. There are new strategies to look even deeper at remission status, and that's by IGH deep sequencing. So this is sequencing of the IGH gene in the malignant cells, essentially a barcode of the malignant population. And in the 20 patients that were able to identify a clone that could be tracked, 65% of them had an undetectable IGH clone by deep sequencing, and another 25% had less than 10 copies. And this was a bone marrow done at a very early stage, only 3 weeks after the CAR-T cell infusion. The responses weren't just restricted to bone marrow. We had 86% of the patients with extramedullary disease achieved complete remission. So you can see here on the right, patient with extramedullary disease in the scapula, retroperitoneal, and inguinal lymph nodes. After CAR-T cells, he was in complete remission. So it's really quite a potent therapy, and one of the things that we're obviously interested in is what are the CAR-T cells actually doing. So these flow plots show blood samples taken at various time points up the top here after CAR-T cell infusion. And we're looking in the boxes at EGFR-T positive CAR-T cells. So this is the transgene marker tag that we have. So anything in the box is a CAR-T cell. We're looking at CD4 and CD8 T cells here. And as you can see, for the first few days, there's really not much activity, but after about a week to 10 days, we start to see a very rapid increase in the number of CAR-T cells out in the blood. And if you look at this in a graphical format, This is showing the percentage of CAR-T cells in blood by day after infusion, but the absolute count is really very similar. You'll note that this is a log-10 scale, and we see really very little activity for the first week, and then we see an enormous expansion very, very rapidly as the CAR-T cells come out into blood. So what we're seeing is that the CAR-T cells are seeing tumour, there's signalling, there's proliferation, secretion of cytokines. When the cytokines and the CAR-T cells get to a high number, we start to see significant toxicity, and we'll talk about that later on. And the idea is that the patients, much the same as an antiviral T-cell response, they undergo expansion and then contraction, and then the patients are left with this surveillance response, ideally to prevent relapse. So what's driving the CAR-T cell expansion? So these two graphs just show patients with ALL. And in the red, these are patients who had greater than 5% blasts. So these are the malignant cells in their bone marrow prior to therapy, and in the black, the patients with less than 5% blasts. And so you can see the patients who had a higher tumour burden before therapy in both the CD4 and the CD8 compartment, we see much higher expansion and greater persistence of the CAR-T cells. So this is likely to be a reflection of just an increased amount of available antigen that's really driving the CAR-T cells. So tumour burden impacts CAR-T cell expansion. The other thing that we found was that the infused CAR-T cell dose level affected the expansion. So here you can see the patients who received dose level 1, which is the lower number, had a peak of expansion about at day 14, whereas those who get a higher dose at dose level 2, which is 10-fold higher, had an earlier and a higher peak of expansion. So the implication here is that if you put in a small number of T cells, it takes them a little while to proliferate and warm up before you actually get to peak levels. So this was the first demonstration that there was actually a dose-response relationship in CAR-T cell immunotherapy. And I'm going to come back to those two factors a little bit later on. In the early part of the study, we were using cyclophosphamide lymphodepletion with or without etoposide, but importantly, we were not using fludarabine in this early part of the study. And we saw a high CR rate. 10 of the 12 patients got into CR, but unfortunately 7 of those 10 patients relapsed within a few months of therapy. And relapse was associated in, I think, all but one case with loss of CAR-T cells in the blood by PCR. So one of the first questions we asked is whether or not repeated CAR-T cell infusions could actually prevent or treat relapse disease. So this slide just shows 5 patients with relapsed or persistent disease who received a second cycle of lymphodepletion and a CAR-T cell infusion. And what we're looking at is just the number of CAR-T cells on the y-axis and the number of days after the first CAR-T cell infusion. In blue is the first infusion, in red is the second infusion, and in all but one case, the second infusion was administered at a tenfold higher CAR-T cell dose. And what you can see in all of these patients is that there's really minimal response to a second CAR-T cell infusion. The tumour burden was equivalent at the time of the first and the second infusion, so this really suggested to us that there may have been an immune response that was actually causing rejection of the second CAR-T cell infusion. So we set up some in vitro assays, and we were able to identify that there was a CD8 T-cell mediated anti-CAR transgene immune response. This is a rejection of those infused T cells based on the presence of neoantigens in the CAR. And when we actually did mapping studies using overlapping peptide panels, we found that most of these responses actually mapped to the murine SCFE. So we've actually now got a study that is in development where we're actually looking at a fully human SCFE to see if we can minimize the effect of these immune responses. So obviously, introducing a human SCFE into the CAR is one way to get around this immune rejection of second CAR-T cell infusions, but that didn't really solve the problem for the patients who were immediately enrolled in the trial. So one of the things that we considered was whether or not if we could actually intensify the lymphodepletion prior to giving CAR-T cells, could we actually minimize the priming of an immune response against the CAR-T cells? So we did that by adding fludarabine into the lymphodepletion regimen. So this is showing, again, CAR-T cell expansion on the y-axis, days after infusion on the x-axis, for patients who received cyclophosphamide and fludarabine lymphodepletion in red, compared to those who received cyclophosphamide-based lymphodepletion without fludarabine in black. And you see the patients that got the Cy-Flu lymphodepletion had a much higher level of CAR-T cell expansion, and persistence. And you see that's about a 1 to 2 log increase in the numbers of CAR-T cells. And this was due to a number of reasons. It was a delay in the priming. It was also an improvement in the homeostatic environment with better lymphodepletion. But in addition to increasing the CAR-T cell numbers, we also found that the addition of fludarabine in red actually improved disease-free survival in these patients and appears to improve overall survival. These are obviously early days. These numbers are only going out to about 2 years, but in our hands at least, the addition of fludarabine has been a big positive in the study. Despite the fact that we were able to get good CAR-T cell expansion, good CAR-T cell persistence, we did have some patients who actually relapsed. And you can see here, this is an example of a patient who had plenty of CAR-T cells in red at the time of relapse disease. When we looked at the phenotype of this relapse, we actually found that it was CD19 negative. So this is a case of CD19 negative immune escape. So you can see on this slide, the blasts in red clearly express high levels of CD19. The patient went into complete remission. You can see there are no blasts there by flow cytometry. However, about 3 to 4 months after CAR-T cell therapy, the patient relapsed with CD19 negative ALL. And the mechanism, or one of the mechanisms for this was reported recently by the group from UPenn. It was an alternative splicing of CD19 that actually essentially knocked out the epitope that was recognized by the CAR-T cells. We recently published on a second mechanism of CD19 negative escape, and this one was kind of an interesting mechanism. It was essentially a lineage switch that occurred in the setting of CAR-T cell therapy. So we reported 2 patients, 1 adult, 1 child, and both patients had MLL rearranged acute leukemias. So these are leukemias that are known to have features of both the myeloid and lineage and lymphoid lineage in some patients. So you can see this patient had a CD19 positive leukemia before CAR-T cell therapy. They got into complete remission. I haven't shown the slides here. But then on day 35 after CAR-T cells, so very, very quickly they had this explosive relapse with CD19 negative disease that had acquired myeloid markers, so CD33, CD64, CD13, that were distinct from the expression pattern prior to therapy. And the morphology also changed from lymphoblasts before therapy to myeloblasts afterwards. We tracked, using CGAT, the chromosomal aberrations in isolated ALL blasts before CAR-T cells and AML blasts after CAR-T cells, and that confirmed that it was the same leukemia that we were seeing. So this is another possible mechanism of escape that we identified despite the presence of good CAR-T cell expansion. So if there's this possibility that patients can relapse after CAR-T cell therapy, one of the questions is what's the role of allogeneic stem cell transplantation for patients who get into CR? And the short answer here at the bottom of the slide is that at this stage we really don't know, and there's more data that's needed. But in this sort of first iteration of CAR-T cell therapy for ALL, there are really 2 ends of the spectrum. At one end, you have a young patient without comorbidities who can tolerate transplant well. Perhaps they might have an MLL rearranged leukemia, so they're at greater risk of CD19 negative relapse. Their CAR-T cell expansion may not have been very good. They may have evidence of endogenous B-cell recovery, meaning that their CAR-T cells were not working. If their CAR-T cells are working, they wouldn't get B-cells back. So a patient like this, we probably would transplant. The converse, so an older patient, maybe who's already had a prior transplant, has got comorbidities, so the risk of a transplant is much higher. Let's say they have a leukemia that had very high uniform CD19 expression, great CAR-T cell expansion and persistence with ongoing B-cell depletion and evidence that the CAR-T cells are still working. In these people, we probably would not do a transplant. But as I mentioned, we really need to do a little more work on this to be definitive about that. So I'm going to move on now to talk about patients with CLL. So I'm just reporting now data that was presented at ASCO this year. We reported 13 patients with a fairly typical median age that you would expect from CLL. The important thing to note from this slide is that these patients were all very high risk. So a majority of them had a high-risk complex karyotype or deletion 17p or other cytogenetic abnormalities that I haven't shown on the slide. And all of the patients had prior ibrutinib. If you look at the median survival of patients who failed ibrutinib for refractory CLL, it ranges somewhere in the order of about 3 to 6 months. So this is a very high-risk population. Median of 66% abnormal B cells in the marrow, and most of the patients received cyclophosphamide and fludarabine lymphodepletion. So this shows the response rates. You can see that the overall response rate was 91% when we look at the Cy/Flu treated patients. The CR rate was 45%, and interestingly, the rate of clearance of disease from the bone marrow by high-resolution flow cytometry was 91%. Bulky disease was amenable to therapy, so this is a patient who had obviously a lot of disease in the neck, the axilla, mediastinum, retroperitoneum, and this patient achieved a CR. You'll note that this is a PET scan, and PET scans are not really commonly used in CLL, but we found that basically 96% of the patients that we've treated on this study with CLL have had FDG-avid disease on a PET scan. Again, sort of highlighting the much more active and refractory nature of these patients' disease. IGH deep sequencing in CLL has been shown to be associated with duration of response. And when we looked at the patients who achieved complete remission, we were able to identify a clone in 4 patients. In all 4 of those patients in complete remission, we couldn't find that clone after CAR-T cell therapy. So this slide just shows the progression-free survival of patients who achieved complete remission and the overall survival. As you can see, a failure to achieve complete remission resulted in a fairly short survival in this group. I'll move on now to non-Hodgkin's lymphoma. So we recently published this in Science Translational Med and also presented updated data at ASCO. So I'm going to present 41 patients from this group. These are patients, the majority of whom had aggressive disease, either diffuse large cell, de novo, transformed diffuse large cell, or primary mediastinal B cell lymphoma. They were very heavily pretreated, as you would expect. About half of them had had a prior transplant, either an auto transplant or an allo transplant. The other half were basically ineligible for transplantation because of their refractory disease. And about 3/4 of the patients received cyclophosphamide and fludarabine lymphodepletion. When you look at the response rates, in the early part of the study, as with the ALL patients, we were using a non-fludarabine containing lymphodepletion regimen, so cyclophosphamide or toposide. And we found the same thing, that some of these patients were rejecting their CAR-T cells, and therefore we added fludarabine for subsequent patients. And you can see that the addition of fludarabine dramatically increased the CR rate and also increased the overall response rate. When we looked at patients who were treated with a maximum tolerated dose in these patients after cyclophosphamide and fludarabine, this was dose level 2, we found in this group that the CR rate was 50%, and the overall response rate was 80%, and this is by the Lugano criteria. These slides show probability curves of the likelihood of response compared to lack of response, so likelihood of CR and PR compared to no response. And we're looking here at CD4 CAR-T cells on the left and CD8 CAR-T cells at the peak of expansion in blood on the right-hand side. And what you see here is essentially these circles represent patients and whether or not they had a response. So these patients down on the x-axis had no response. Those with a probability of 1 had a CR or a PR, same thing on this graph. And so this is a mathematically derived curve that is essentially looking at the probability of achieving a response with increasing levels of CD4 CAR-T cells or CD8 CAR-T cells. So this was also one of the first times that we were able to actually show that the peak of CAR-T cell expansion actually was associated with the likelihood of achieving a response in these patients. was also associated not just with the likelihood of achieving a response, but also with the quality of the response, with a CR versus lesser degrees of response. And you can see in here also that the presence of fludarabine in the lymphodepletion also improved the quality of the response in non-Hodgkin's lymphoma. The peak of expansion was not the only thing that was important, but the persistence also was key. This was a patient with a primary mediastinal B-cell lymphoma. He had a large FDG-avid renal mass before CAR-T cell infusion. And he had his treatment, Cy/Flu, with CAR-T cells at dose level 2. And then at day 28, after his CAR-T cell infusion, we restaged him. And the PET was disappointing. The actual mass itself was larger. It was still highly FDG-avid. And we debated whether or not we should give this patient a second CAR-T cell infusion. It was a little confusing because the patient had very high levels of CAR-T cell expansion, very high persistence. So we decided we would actually biopsy this patient's tumour. And it turned out we didn't actually biopsy a tumour. What we biopsied was T cells. So there was no tumour detectable at all in this mass on biopsy. What we did see was that a majority of the cells in there were actually these EGFR-T positive CAR-T cells. So after a bit of angst, we just decided to watch and wait and not do anything with this patient, and did a PET scan a month later, and he was in complete remission, and he remains in complete remission now about a year and a half out. So CAR-T cell expansion is important for getting into remission. CAR-T cell persistence is important for staying in remission. So Cy/Flu has a big role in helping out with this. So this just shows the progression-free survival and the overall survival of patients with non-Hodgkin's lymphoma who achieved a CR or didn't achieve a CR. And obviously the numbers here are not high, but we're working on increasing those numbers in the trial. So I think some of you here probably looked after CAR-T cell therapy patients on the inpatient service and know that they can actually get pretty sick from this therapy. And when you think about the toxicities of CAR-T cell therapy, you can split them up into a number of categories. They obviously get lymphodepletion chemotherapy, so they're all the adverse effects that you would expect associated with chemo. They can get off-target toxicities, and by that I mean allergic reactions to serum proteins and things used in CAR-T cell manufacturing. But these things are not particularly common, and at least to date have not been particularly serious. There's also a risk of on-target, off-tumour toxicity, and by that I mean the activity of CAR-T cells against CD19 expressed on normal B cells. So these patients can get profound B cell depletion, and in some cases need prolonged monthly replacement with IVIG or the use of prophylactic antibiotics to minimise the risk of infections. The bigger area, problem area of toxicity is these last two categories. So on-target, on-tumour toxicity, and cytokine release syndrome is really the main thing. So this is the effect of activating the T cells when they actually encounter the antigen expressed on the tumour. And the last one is neurologic toxicity. So if you think of the problems that we can see, there's a bit of a clinical spectrum that we see of fever, hypotension, capillary leak, hyperferritinemia up to extreme levels in the tens to hundreds of thousands. Coagulopathy and DIC and multi-organ failure can occur. I've called this classical cytokine release syndrome and separated it from another manifestation of toxicity, which is neurotoxicity. And no one really quite understands neurotoxicity, but it can come in all different shapes and sizes. Most common is just that patients can develop a delirium. They may be just somnolent, they may be slightly disoriented, lose track of time. In its more severe forms, they can actually develop word-finding difficulties or aphasia. We've had patients who've had some very bizarre word-finding problems. One patient who repetitively flipped words over the course of a number of days. So he would, the nurse would come in to take his temperature, and he'd say, "Why are you here? You took my privacy 20 minutes ago. Why are you doing this again?" And then 20 minutes later, he'd get up to go to the bathroom, walk into the bathroom, and as mothers do, his mother would follow him into the bathroom and she'd say, "Just leave me alone, I just need my temperature." And he was flipping those two words repeatedly over a number of days. So we've actually seen two patients, not the same words, but two patients who've had that sort of issue. Patients can develop seizures. They can develop coma, and neurotoxicity can be fatal due to cerebral edema. In the vast majority of cases, importantly, the neurotoxicity is completely reversible, even when it is profound. So we've had patients on ventilators due to neurotoxicity who have completely recovered, in some cases, extraordinarily dramatically, up and riding a bike within a month of being in ICU on a ventilator. So to try and grade toxicity, a system has been developed a little bit analogous to the CTCAE system, looking at grade 1 being mild toxicity, basically just a fever, all the way down through grade 5, which is death. It's not the best grading system in that if you look at grade 2, this can be someone who has hypotension that's responsive to a 250 ml bolus, or also in ICU on 1 vasopressor. So the grading system is a little on the hazy side, but essentially when you're getting into grade 3 toxicity, you're in pretty serious territory, and you're likely to be in intensive care. This slide is not designed to give you a seizure or put you to sleep, but it's just to try and give you a bit of a feel for what we actually see with these patients. So the different coloured graphs, different coloured lines on each graph are different grades of cytokine release syndrome. So in red is grade 4 to 5. So these are really, really sick patients, life-threatening patients, or patients who ultimately died. Grade 1 to 3 is anyone from a fever up to the point of being in ICU, but pretty stable in ICU. And grade 0 are patients without any cytokine release syndrome. Obviously, the number at risk here of patients declines as we go out to in the grade 4 to 5 group, because some of these patients actually died before we got to later time points. So each graph is looking at a time point in relation to CAR-T cell therapy, and then the parameter on the y-axis. So you can see the patients who do really badly get sick very, very quickly. These patients are developing high fevers within the first 24 hours after CAR-T cell infusion. They're becoming tachycardic, dropping their blood pressure, systolic and diastolic. Their respiratory rate is higher than other patients. They're beginning to develop capillary leak, dropping their protein and albumin, and developing weight gain. In contrast, those that have lesser degrees of cytokine release syndrome or no cytokine release syndrome really don't change much throughout the course of therapy. We also see hematopoietic effects of severe CRS in patients who are really sick. Are often much slower to recover their ANC. They can be slower to recover hemoglobin and hematocrit. Interestingly, their monocyte counts are often low. We don't know if this is an effect on hematopoiesis, but I suspect it's probably related to migration and activation of monocytes and migration out of the blood. As I mentioned, we do see these extremely high ferritin levels in some of these patients, and a macrophage activation syndrome. The patients can develop a coagulopathy, and one of the mechanisms by which we may see toxicity occurring, clinical toxicity such as neurotoxicity occurring, could be through an endothelial injury. There's a lot of work that we still need to do in this area, but we do see the really bad patients developing elevations in D-dimer. They drop their fibrinogen. This often occurs fairly late and coincident with the onset of neurotoxicity. We see increased levels of PT, increased PT and APTT, and we also see low levels of platelets, much the same as we saw with the other hematopoietic data. So that's sort of just to give you a bit of an idea that these patients, when they have bad CRS, they are pretty sick. So this slide just shows, with a breakdown by disease, the number of patients that we're seeing with different grades of cytokine release syndrome, and also with significant neurotoxicity. So this is grade greater than or equal to 3. So you can see that a majority of people who actually get CRS are getting pretty mild CRS that's dealt with fairly easily, just with hospital admission for fever and some IV fluids. But depending on the disease type, around about a quarter or so of patients will actually have more significant cytokine release syndrome, and some patients, as I mentioned, have died of complications related to CRS. Overall, the number of days that are spent in hospital is not particularly high. It's about a week, basically, across each of the 3 different diseases. One of the things that we notice with the toxicity was that, at least particularly in ALL, that this was very closely related to the number of marrow blasts that they had prior to starting therapy, so the tumour burden prior to starting therapy. So you can see that a requirement to go into ICU, these patients in black went into ICU, these ones in black and blue had more severe neurologic toxicity. You can see that those with high tumour burden and thus sort of driving their CAR-T cells to higher levels of expansion were far more likely to end up in ICU with severe neurotoxicity. So one way that we tried to deal with this was actually by doing a risk-adapted dosing modification. And the idea of this was that if a high fraction of marrow blast was driving higher CAR-T cell expansion and then worse toxicity, why couldn't we just flip the CAR-T cell dosing regimen so that people with a lot of tumour got a lower dose of CAR-T cells and those with less tumour got more CAR-T cells, with the idea that you would even out the maximal level of CAR-T cell expansion. So we actually instituted this risk-adapted CAR-T cell dosing, and something odd has happened with the Mac to PC formatting here. But when you look at these patients with greater than or equal to 20% bone marrow blasts who have the highest risk of toxicity, so these are people above this point here on the slide, if you treat them with greater than or equal to 2 by 10 to the 6 CAR-T cells per kilogram, all the patients ended up in ICU and all of them had significant neurologic toxicity with a median of grade 4. So this is life-threatening neurologic toxicity. When we did the risk-adapted dosing and we decreased the dose to 2 by 10 to the 5th per kilo, only one of those patients ended up in ICU and only 40% of them ended up with neurotoxicity, and the median grade was grade 3. So just that simple modification of backing off on the dose for those with high tumour burden was very effective in reducing toxicity. But obviously there's a limit to how far you can go when you back off on the dose before you start to lose response. So this slide shows a probability curve, and this is actually in patients with non-Hodgkin's lymphoma. And what we're looking at here on the y-axis is the probability of the outcomes shown by each of these different coloured lines. Red for probability of any response, blue for probability of CR, green for probability of neurologic toxicity, and brown for severe cytokine release syndrome. And these curves are, like the previous ones I showed, the x-axis is increasing CAR-T cells in blood. So if you drive the peak of CAR-T cells higher and higher and higher, your CR rate is going to go up. But at some point, you're actually going to get into trouble where you end up with an overlapping probability of severe CRS or neurologic toxicity. Conversely, if you back off on the CAR-T cell dose to decrease the risk of toxicity, your likelihood of responding is also going to go down. So there's a little bit of a problem there in just sort of simple dose modification as a way of getting around toxicity. So there are other things that we need to look at. One thing that we did was to actually look at different cytokines at the peak of CAR-T cell infusion. And this graph on the left-hand side is just showing basically the cytokines that we found that were significantly higher in patients who had serious neurotoxicity compared to those with much lesser degrees of neurotoxicity. And you can see that IL-15, TGF-beta, IL-6 were significantly different, amongst others, in the patients with neurologic toxicity. IL-6 is really a key player in this, and I'm not going to talk about it much, but one of the ways that we can actually treat these patients is with an anti-IL-6 receptor antibody to block the effect of IL-6 along with corticosteroids. And that's very effective for treating patients with severe cytokine release syndrome, not so effective for treating patients with neurologic toxicity. So targeting cytokines that appear to be key players at the peak of expansion of the CAR-T cells during toxicity is one approach. The other approach that we looked into was to see whether we could actually identify patients early on who were at risk of toxicity. And all of that data on the temperature, the heart rate, diastolic, systolic blood pressure going down on the first day, that's one way we can identify patients who are at high risk, who might be amenable to early intervention. The other way is actually by looking at the cytokines on day 1 after CAR-T cell infusion. So here you can see that there are a number of cytokines that were significantly different in patients who did or didn't develop severe neurotoxicity just within the first 24 hours after the CAR-T cell infusion. And when we actually took the three most significant cytokines and developed ROC curves and prediction algorithms using these three cytokines, we were able to identify a correct prediction of severe toxicity in over 90% of the patients. So this is sort of setting up a platform now as we go forward to expand the data set and consider strategies to use early intervention to try and be able to maintain these high CAR-T cell doses with good CAR-T cell expansion and get good responses with limited toxicity. So just to wind up, the approach that we've taken with the defined subset composition CAR-T cell product has shown very good response rates in ALL, non-Hodgkin's, and CLL. The second point is really that optimization of CAR-T cell dosing and lymphodepletion and careful study of the outcomes is really helping us to improve our clinical outcomes. But the third point is probably the most important one here, that we still have a long way to go. So just in the interest of time, I'll wind up here. I won't go through everybody in this list, but just to acknowledge Dave Maloney and Stan Riddell, with whom I've worked very, very closely on for this project. The work started in Stan's lab many years ago, and Dave Maloney is a clinical co-PI on these studies. So thank you very much for your attention, and I'd be happy to take any questions.